Blood products and hematology issues. So first thing we're going to go over is blood products and different transfusions. So you do have multiple different types of blood products that we deal with. You're already familiar with packed red blood cells. That's also called whole blood, fresh frozen plasma, platelets, and crypto. We'll talk more about each of those. So why would a patient need a transfusion in the first place? Okay. So excessive blood loss, possibly a traumatic injury, a surgery, a bleed out. Severe anemic patients with a hemoglobin less than 7, and assessment findings. If they're positive for anemic assessment findings, so low blood pressure, high heart rate, high respiration rate, fatigue, shortness of breath, whiteness around tips of their fingers, around their mouth, those are other indications for a transfusion. Kidney failure, they can get packed red blood cells as long as they're not in fluid volume overload. We give fresh frozen plasma to individuals that are having clotting factor deficiencies, so individuals that are fighting hemophilia. Platelet patients, a normal platelet count is 150,000 to 400,000. We typically give platelets once they get less than 20,000, or if they're actively bleeding and they're dropping below 50,000. We do give crypto a lot for hemophilia A and possibly Burns or hypoprotein patients. So packed red blood cells, better known as whole blood. We typically transfuse this between 2 and 4 hours, never above 4 hours. Once the 4-hour mark has hit, we will stop the transfusion because of coagulation fear. Once you're giving whole blood, 1 unit should increase a patient's hemoglobin by at least 1 point, if not more. Very often too, when we're giving packed red blood cells to patients, we are giving small doses of Lasix, so 10 to 20 milligrams IV push, to prevent the buildup of potassium and the buildup of fluid. Fresh frozen plasma. Fresh frozen plasma, we give a lot for clotting factors. We can give FFP very, very rapidly. You can give it in less than 30 minutes. You'll see ER staff, ICU staff open this up and let gravity do it a lot, especially in times of critical or urgent care. This would be something we give patients that need to have an emergent surgery and they're on an anticoagulant. So say you have a patient come in, they have to have an emergent surgery, and they're on warfarin every day. We're going to give FFP in pre-op and the first part of the surgery to reverse that and fight the coagulation factor that the medication does. Platelets. Love platelets. Platelets also you can transfuse very rapidly, 15 to 30 minutes. You don't actually need a type and cross, but it's always good to have. In the matter of emergencies, we're gonna probably waive the type and cross and just get it in. We do give this a lot with thrombocytopenia patients. That does help with their clotting factors because especially idiopathic thrombocytopenia, they like to bleed. So those are individuals you're putting a lot of pressure on if we have to give them an IM injection or put an IV in. All right, crypto. We give crypto a lot for clotting disorders and burn patients. This is also fairly rapidly to give, and it doesn't have a whole lot of milliliters in there, so we can get it going pretty darn fast. So here are all the different blood types. So what are we going to do pre-transfusion? All right, what are we going to do pre-transfusion? So we're going to be doing the patient's vital signs. We want a pre-transfusion vital signs. The RN does need to stay at the patient's bedside for the first 15 minutes. We're going to be watching for signs and symptoms of a transfusion reaction. Blood products do need a consent. The RN can get the consent for this. You do not need a medical doctor to get consent. We can consent for this. The patient's going to need a large bore IV, prefer 18. We can get 20. 22 is not ideal. Once you get the blood product to the patient, you do need a 2 RN check or an RN and an MD check to verify that everything is correct. So when you're looking at the bag, we're looking to make sure that the blood is compatible. If there's an RH factor, that's compatible. The expiration date, the unit number, and the patient name. The only IVs we give with blood are 0.9 normal saline, nothing else. So intratransfusion, so it is actively going. This is when we're looking at the patient, allergic reaction, febrile reaction, hemolytic reaction, okay? We're going to be asking the patient if they're short of breath, you have any chills, you have anything starting to itch, any pain anywhere. So if you don't remember, you need to look at what happens with blood transfusions and why they can get hyperkalemia. We have to assess for the calcium and the mags. You might want to brush up on that if you don't quite remember why. So let's talk about the reactions. So febrile reaction is the most common one you are going to see, okay? Febrile reaction is they do get a temperature, but it's not critical. They get the chills. They might get a little hypotensive, a little tachycardic. So if this is happening, we're going to stop the transfusion. We're going to start the 0.9 normal saline. If you do not have medication orders, call the doctor because you're going to want Benadryl and Tylenol, and then document. So those are the 5 steps. We'll go over them again. Stop the transfusion, start the 0.9 normal saline, call the MD, get Benadryl and Tylenol orders, and then document. A hemolytic reaction is going to be much more severe. This is the one that you're not going to see a whole lot. It can be mild, and if it's life-threatening, we do have to move incredibly fast. So what's happening is the immune system starts destroying the RBCs that you're giving it, and it causes It can cause a fatal reaction called DIC. It also can very rapidly lead to renal failure because at this point, because of the the immune system attacking, it can cause the kidneys to start shutting down. This patient will, if they're able to, we're going to see if we can get them on dialysis right away to reverse the problem. And allergic reactions, anything you can get allergic reaction to. Could be anything from mild hives to life-threatening, and we're doing anaphylactic shock protocol. You don't see anaphylactic shock a whole lot, but it is a possibility. So very typically, the patient's going to get hives, they're going to be itching, and we do typically, after we stop the transfusion and give normal saline, you're again calling the doctor for Benadryl and Tylenol. Another thing that you can see, though it is rare, you can see it, is something called transfusion-related acute lung injury. This is actually when the patient goes into pulmonary edema and it is life-threatening. It may not always start in the first 15 minutes, but statistically, if it's going to happen, it happens in the first 6 hours. This patient may need to be intubated, put in a medical-induced coma so we can rest the lungs. Sometimes what happens is there's a circulatory overload issue. And this typically is happening because the blood has been given too fast. Maybe the patient had some respiratory issues to start off with. Maybe they had some congestive heart failure to start off with, and the blood was just too much too soon for the body to process it all. So these would be the patients that we want to give this unit of blood over the full 4 hours, so we're not overloading the patient. But they're going to be tachycardic. They're going to have shortness of breath. They're going to have the crackles. They're going to have the bounding pulse, the JVD in their neck, and they're going to be restless and really anxious. So don't worry about the differences between Charlie and Taco. They're not on the test. So. All right, so once again, if you suspect a reaction to transfusion, stop the transfusion. Flush the line with normal saline, only normal saline, 0.9 normal saline. Call the doc, get the Tylenol and Benadryl orders, and the last thing you're going to do is chart. So, an assessment. So when we're looking at patient history, we want to know if there's a family history, if they have a history of bruising, what medications they're on, both prescription and over the counter. Nutritional status, are they getting enough protein in their diet? Family history, and any current health problems that could be causing any type of hemo issue. We're going to be looking at the skin, the head and the neck, any shortness of breath. And here's the bad part about hemo and shortness of breath. They can have shortness of breath if there's not enough blood in their circulatory system, or they can have shortness of breath if there's too much blood in their circulatory system. So hematology conditions. So let's talk about some specific blood order conditions, okay? Idiopathic thrombocytopenia purpura, short ITP, okay? This is an autoimmune reaction in the body where the patient naturally has low platelets. The actual number can vary, so we're not going to worry about the actual number, but they can have severe bleeding if they have any type of cuts or lacerations. For medications for treatments, physicians tend to use corticosteroids and immunosuppressants. They can get blood transfusions or platelets as needed. And for the nurse aspect, if we do have to give an IM injection, sub-Q injection, we're just going to be holding pressure for a long time. We're talking 10 to 15 minutes of holding pressure because they can really just start bleeding out. Not bleeding out, but bleeding severely from the site. So they can also get all these little purpura dots, and these are from cells rupturing in the subcutaneous tissue. And while this is not life-threatening, it can be very alarming for patients if they have no idea that they have ITP. Then you can get something called heparin-induced thrombocytopenia. This has absolutely nothing to do with idiopathic thrombocytopenia. Absolutely nothing to do with it, okay? This is brought on by an immune response when somebody gets heparin. But we give millions of people heparin in the country every year. They don't have reactions. So it can be a very small reaction base to it. There are some risk factors. Being female, you have a higher risk of it. Receiving heparin injections for more than a week. So sometimes we have heparin sub-Q injections for blood clots. So we will be watching the patient. If at all possible, you're going to see physicians go from heparin injections to Lovenox or PO medications just to get them off the heparin, okay? And I've never had a patient on a heparin drip in the hospital more than a couple days, so that's usually not an issue. So the horrible DIC, disseminated intravascular coagulation. This is a life-threatening disorder, and it can take the patient's life very, very rapidly. What happens is it triggers all the platelet and clotting factors from one extreme to another. So the patient's going to have bleeding, they're going to have blood clots, they could just start bruising everywhere. They're going to be short of breath, crackles in the lungs. We don't have much time because they can go into septic shock within an hour of this setting in. And sometimes we don't even know what's happening until we're practically in a code situation. Usually the treatment is high doses of heparin to try to get the clotting factor to balance out. But let you know, these particular patients don't tend to survive DIC. You absolutely can, but usually the body's in such disarray with the blood either clotting too much or not clotting enough that patients don't tend to make it. On that note, just do an overview and a couple things before I let you read the fabulous questions and get the answers from those. Just remember that if you do have a patient, religion-wise, opinion-wise, that they do not want blood and it's highly recommended, there's nothing you can do, but you absolutely 100% should chart that the patient has declined the blood products. It's just a good idea to do. If you have a patient actively bleeding, a lot of times we do use cryo, especially if it's a trauma. Okay, if cryo is a trauma. If they're actively bleeding from like a GI bleed, like they have an ulcer, we're usually going to go whole blood. So that's the differences between those. And the last thing I didn't talk about was if you're going to give FFP to patients that are taking Coumadin or warfarin, we do want to make sure the warfarin's been DC'd, at least during the time of giving the FFP. There's no point of giving them FFP and keeping them on warfarin, okay? Always get that large bore IV, so we're talking about 18 to a 20 gauge. Stay there. We're doing a blood product, so stay there and watch for reactions. Assess the pre-labs to the post-lab, see if anything changed, and make sure you get that patient consent. All right, you guys, that is it. I will see you soon.